the four pressures? What determines capillary fluid pressure? That's very good. So with a drop in systolic blood pressure, there's going to be a drop in capillary fluid pressure. And you got your H-thal. And embedded in your H-thal membrane, what do you get? You got those little osmoreceptors, right? Tell me you're with me. And there's going to come a point where the guy loses enough blood where capillary fluid pressure is going to become lower than interstitial fluid pressure. And it is going to force fluid from the interstitial space and cell into the blood in an attempt to maintain blood volume. So what will happen to the osmolarity of the H-thal? You are keeping the stuff the same, but what's being reduced? So what will happen to the osmolarity? When it goes up, that stimulates thirst. Watch. Watch. I never told you this. I'm going to tell you this now. When a person has surgery, why can't they drink water? Why can't they have something to drink right after surgery? They checked it. They're not bleeding. Why can't they have anything to eat or drink right after surgery? It does. Watch. That's why after surgery, what you do is you ask the patient, hey, are you farting yet? And if you ain't farting and you don't hear any bowel sounds are the result of the GI tract going through peristalsis. When you undergo surgery, you get generally anesthetized, including your intestines. Are you with me? And if you eat something or drink something and your intestines ain't working, you will throw it up. Say yes. But watch. Watch. Does it take time to get the water that you drink into your bloodstream to lower your osmolarity so you're not thirsty? Yes. But watch. When you drink something, as soon as you're done drinking it, your thirst is quenched. And that water hasn't had time to get into your bloodstream. That's because you have little osmoreceptors in the back of your throat. And when it detects that change in osmolarity because you're putting fluid in it, that quenches your thirst. Watch. Watch. Ice has 1/10 the water content that water does. So when people come out of surgery and they can't drink, they give them ice chips because that will stimulate the osmoreceptors and decrease their drive to be thirsty. That's rock solid right there. Am I right? Everybody at break, 56 cents extra. How many people followed that? So when the osmolarity goes up, that's going to trigger osmoreceptors. Now watch. Now think about this for a minute. If you are losing fluid or you're dehydrated and your osmolarity is high, that means you don't have enough water. So you want to be peeing? No. So the hypothalamus makes a hormone called antidiuretic hormone. And what's directly connected, and the size is not indicative of the actual size. Hanging off the H-thal is the little pituitary, the little dingleberry there. And ADH is transported from the H-thal into the posterior pituitary. And the ADH is released into the blood. Are you with me? Here we go. Look, and I know I told you this. I'm going to tell you this again. Watch. If you were to draw a line of osmolarity from the cortex into the medulla, what happens to the osmolarity as you move deeper and deeper into the medulla of the kidney? It goes up. You better write this down. The collecting tubules, in the absence of hormones, are impermeable to water. So whatever the amount of water is in the collecting tubules, if there's no hormones around, that's the amount of urine that you're going to produce. You just told me that if you're bleeding your own blood, do you want to be peeing a lot? No. So the function of ADH, and this is exactly what it does, is it will stimulate the cells that make up the collecting ducts, and it will insert water channels into the collecting ducts. Aquaporins. And when these aquaporins are formed by ADH, it will allow water to get reabsorbed back into the bloodstream. Tell me you got that. Now watch. As the person's blood volume begins to decrease more and more, what's going to happen to the osmolarity within the hypothalamus? It will become what? Higher and higher, or lower and lower? Say higher and higher. Good. Watch. If you're losing more water because your blood volume's dropping and your systolic blood pressure is dropping, therefore your capillary fluid pressure is dropping, more fluid is going to be pushed from the cells into the interstitial space and then ultimately the capillary. You got me? So the osmolarity is going to go up. So as the osmolarity begins to go up, ADH will insert aquaporins farther down the collecting ducts. And because the osmolarity increases, more and more water gets reabsorbed back into the blood. With maximum ADH secretion, there is no urine output at all. That's why, watch, under the effects of hormones and with pressure diuresis, if you give that person a fluid challenge and their cardiovascular system is not intact, they won't get any urine output. And even though you can get more blood flow to the kidney, the effects of ADH are going to draw that water into the bloodstream. Tell me that made sense. That is, of course, beautiful.
And that just keeps cycling back. So how do you get rid of the aquaporins?
What you do is you stop them from bleeding. Then you increase their blood volume. The osmolarity decreases. There's no longer ADH, and then these will there's downregulation. You'll just get rid of them. So the ADH, the hormone, actually stimulates the cells that make up the collecting ducts to build these protein aquaporins and stick them in. Boom. Yeah, it's very quick. It's very quick. Remember, you're making like proteins. You're making 20 proteins a second. Right there in my duodenum, I make 22 proteins right there. Tell me you follow that. Now, I made mention of this, and I'm going to make mention of this again. There are two pathologies associated with ADH. One is diabetes insipidus. And that's a really fancy couple of words for no ADH. So if you have no ADH, what are you doing all ADH day? What are you doing all day? You're peeing all day. And this is very important. Write this down, tattoo it someplace. ADH deals with pure water. Water only. Water only. The other one is where you have too much ADH. And that is called syndrome of inappropriate ADH. Too much ADH. So they're not peeing much at all. And what's happening to their blood volume? It's really high. So what's going to happen to their blood pressure? Way up. Do you follow this? And because you're reabsorbing water and you're not reabsorbing electrolytes, then they can suffer from hyponatremia, a dilutional hyponatremia, right? Because you're adding more water and you're not adding more salt. So one of the things you have to do with these people is you have to give them salt. You have to give these people salt tablets. Otherwise, the low osmolarity in the blood will cause fluid shifts into the brain. They can die, right? So with people with diabetes insipidus, you give them ADH. The drug ADH is not called ADH. It's called vasopressin. So if you ever see vasopressin, have you ever seen vasopressin? That's ADH. And the reason it's called vasopressin, what does ADH do? It indirectly increases your blood pressure by reabsorbing water, right? That increases your blood volume. But it also causes some mild vasoconstriction too. Vasopressin. You like that? Little side note here. Little side note. Alcohol inhibits ADH's ability to insert aquaporins in the collecting ducts. That's why you pee a lot when you drink alcohol. That's why when you take your first leak, when you're drinking, there's some yellow in it, but your subsequent leaks are clear because you're inhibiting the effects of ADH. That's why you wake up in the morning and you got cotton mouth, right? You say, I'm never doing that again. Ain't that right, Sadaka? Never doing it again. You drink? Sometimes. Right after this class, huh? Probably go to the Blue Sombrero, huh? Sucking them down. Tell me you got that. So when I worked in the ER, like firefighters, they come in and they be all hungover. They go, Tim, can you treat me? And I go, yeah. So you give them 2 IV bags of lactated ringers, which has electrolytes, physiologic, and you give them a little oxygen, and then have them sit there for a half hour, and then they could ambulate home. So there. What? That was good information, right? So don't, yeah. It's mostly dehydration. Acute alcohol intoxication, that can lead to, that can stimulate the medulla, right? And because you build up, hold up, you build up aldehydes. What does aldehyde sound like? Formaldehyde. So aldehydes are toxic to the system, and that causes you to throw up. So the metabolism of alcohol, one of the intermediates is aldehyde, and that's why you get sick if you drink too much too fast, because the liver can't detoxify it and break it down to CO2 and water fast enough, so you build up aldehydes. That's how anabuse works. Anabuse works by preventing the liver from taking the aldehyde and breaking it down to CO2 and water. So the aldehydes build up and you get sick. That's how anabuse works. But if you're a good drinker, you can drink right through that anabuse. You throw up a little bit, but then you can go. Oh, sorry. Ready? Tell me you got that. That is the effects of ADH. Are you with me? All right. I went over the renin-angiotensin-aldosterone mechanism, did I not? Did you watch the video? Did you? Did it make sense? Okay, I'll go over it really quick. Do you want me to or no? Okay. All right, watch. One of the things that the kidney does is it maintains and monitors and helps maintain long-term blood pressure. And it does that through really 2 mechanisms, pressure diuresis, which we talked about, and the renin-angiotensin-aldosterone mechanism. Now, a couple of things, just real quick. Number one, renin's an enzyme. What do enzymes catalyze? Right, so they make a chemical reaction happen quicker than it should, right? Continually produced by the liver and in its inactive form is a chemical compound called angiotensinogen. And anything with gen after it is inactive. You got me? Watch. There's an enzyme in the lining of the pulmonary capillaries called ACE, angiotensin converting enzyme. Are you with me? Okay. So I'm just going to give you this background, and I'm going to go through it really quick. Now, again, think for a minute, right? Here's the afferent arteriole. Connected to the afferent arteriole are these specialized cells called juxtaglomerular cells that respond to stretch, right? Juxta means next to. Like, thought that was a good one. I tried explaining this with the juxtaglomerular apparatus. It just wasn't happening. You can go to graduate school and learn about it. I'm going to simplify it for you. Ready? When the kidney sense a drop in systolic blood pressure, juxtaglomerular cells release into the blood the enzyme renin. Now watch. Why was renin released? Because your blood pressure drops. So what do you think renin is going to do? It's going to try to raise your blood pressure. The drop in systolic blood pressure and the juxtaglomerular cells. That would be a good name for a rock group. It's here for juxtaglomerular. The new hit, slow-mo. I like it like that. She's working that back. I don't know how to act. What? That's what I should do. I should do some gangster rap. Yeah. See, that's called juxtaposition. That's funny. An old white guy like me doing gangster rap, people would laugh at that. It's ridiculous. Huh? Yeah. All right. Ready? Okay. Again, renin was released because there's a drop in blood pressure. So renin is going to somehow raise that blood pressure. What's continually produced by the liver, but in its inactive form? So angiotensinogen produced by the liver and dumped into the blood. What do you got in the blood now? You got renin because your blood pressure was low. So renin converts the inactive angiotensinogen into the active angiotensin 1. You better get this. Angiotensin 1 is a mild arterial vasoconstrictor. It will take arteries throughout your body, and it will mildly constrict them. And according to Ohm's flow law, if the arteries get smaller, what happens to resistance to blood flow? And you increase systolic blood pressure to maintain Q. Now, if that settles the issue, right, then you get negative feedback, blood pressure goes up, no need for more renin to be released. Are you with me? And angiotensin 1 lasts about 30 minutes. But in that time, angiotensin 1 lived a good life. Bought a house in Whitecaps, white picket fence, and had 1.5 kids. In that time, angiotensin 1 will circulate to the lungs. And in the lining of the pulmonary capillaries, you have angiotensin converting enzyme. An angiotensin converting enzyme converts angiotensin 1 to the much more powerful angiotensin 2. Angiotensin 2 does two things in one. It is a massive arterial vasoconstrictor, massive. So it really makes those arteries smaller. So what happens to resistance of blood flow? Look at the arrow. And that increases your systolic blood pressure. The effects of angiotensin 2 on arterial vasoconstriction can last several days. But its most profound and long-lasting effect is on the adrenal cortex. And when angiotensin 2 stimulates the adrenal cortex, it will release aldosterone. Are you with me? And aldosterone has its primary effect on the distal convoluted tubules of the nephron. Boy, that sounded pretty good. That sounded like James Earl Jones. This is CNN. Watch. I want to make this good for you, so you're going to feel good about yourselves. How many people feel good about themselves, better about themselves, because they took this class? You do? Really? What's that? Oh, so yeah. Right? Better the devil you know, ain't that right? Look, I get it. Right? Okay, watch. Come on, Timmy. Look, I'm trying hard for you. Embedded in the cells of the distal convoluted tubule is a pump. And aldosterone stimulates that pump. And that pump takes, that is so bad. That pump takes 2 potassiums that were in the blood and pumps them into the urine, and 3 potassiums that was going to be peed into the turlet and pumps them into the blood. And when sodium gets pumped into the blood, what will follow by osmosis? So what will happen to that individual's blood volume? What will happen to venous return, stretch? Can't even go on. So what will happen to the person's systolic blood pressure? Boom. So it is the effects of aldosterone that are the most profound in terms of the renin-angiotensin aldosterone mechanism, in terms of raising someone's blood pressure. The effects of aldosterone can last for weeks or months. Now watch, and I think I mentioned this. There is a diuretic that inhibits the effects, blocks aldosterone receptors in the distal convoluted tubules. It's called spironolactone. Have you ever heard of spironolactone? Have you heard of aldactone? That is a diuretic, and it inhibits the sodium-potassium pump by blocking aldosterone receptors in the distal convoluted tubules. Now watch. Here, aldactone, or aldosterone, it's going to cause sodium to be reabsorbed. If you block aldosterone receptors with spironolactone, can aldosterone exert its effect? No. So if you don't pump sodium back into the blood, what ain't going to be drawn along with it by osmosis? Water. So this is referred to as a potassium-sparing diuretic. Why? Because you don't get rid of potassium because you're inhibiting the sodium-potassium pump by blocking aldosterone. For the crowd. Top flight. Beautiful. Spironolactone, watch it, also blocks the effects of testosterone. That's why dudes who take it start getting man boobies. I'm not lying. And it's also used as a drug to for gender reassignment when a guy is going to a woman, because it blocks the effects of testosterone. Did you know that? Well, now you do. So tell me you got that. Yep.
Is it DHEA or is it aldosterone that gets converted to the sex hormone?
DHEA.
Okay.
Yep.
DHEA. Okay.
And spironolactone, the way it works is it actually blocks DHEA receptors. And it actually works in the testicles too, which reduces the production of testosterone. So you'll see somebody and they don't have high blood pressure and they're on it. They're probably going through gender reassignment. Yeah. That's got to be tough, man. I told you about the dude at the company. All the plastic surgery in the world is not going to make that guy a nice-looking woman. I felt so bad for him, too. And he's so tall. He's like 6'6". But here's the thing. And then he got a new position out in Seattle. And so he was walking down the, by the harbor there. And then these punk kids started, beat him up. And I just thought to myself, what a bunch of... And you wonder why I don't like people. I looked at him, and he knows how I am. And he goes, Tim, I never thought that attitude would come out of you. You're so accepting. I'm like, how could you not be? Do you understand? Look, watch. Your goal and my goal is the same goal, right? To be happy, content. And if you ain't happy, content with being a guy, you want to be a woman, God bless. Well, he ain't hurt nobody. Anyways, spironolactone. Tell me you got that. Did I explain to you why hydrochlorothiazide causes gout? You like that one, huh? Did you like that one? Spironolactone drugs are usually secreted into the distal convoluted tubules, and uric acid and hydrochlorothiazide compete for the same excretion pathway. So if you have hydrochlorothiazide, you'll excrete that and retain uric acid in the blood, and that will cause gout. Yes. Yeah, a lot of drugs get excreted in distal convoluted tubules. Yep.
Why are a lot of blood pressure medications cured with hydrochlorothiazide, like losartan and HCl?
Here's why. Hydrochlorothiazide, outside of the fact that it increases your risk for gout, it's a very mild diuretic, and the side effects of it are very, very low. So what they usually do when somebody has high blood pressure and they don't have anything else wrong with them, then they'll start them on a hydrochlorothiazide, right? Then they'll max out the hydrochlorothiazide, and then if that doesn't work, then they'll start with something else. And that's why they combination drugs. Here's the other thing, too. Watch. When you have a drug, you have, Vasotec, which is an ACE inhibitor, right? When the company that manufactures that, when that patent runs out, then any other company can manufacture that drug under the generic name, which the government gives you, called lisinopril. Are you with me? And because there's more competition, generic drugs are cheaper. So to keep that patent going, they say, we're going to test Vasotec with hydrochlorothiazide and call it Vasoretic. Have you ever heard of Vasoretic? And now that 7-year patent continues, so they make their money. And watch, when you go to a store, not a store, but CVS, Walgreens, right? You don't say, where are your tissues? You say, where are your Kleenex? Right? When you go and you were on Claritin and now it's over the counter, you don't say, where's my Loratadine? You say, where's the Claritin? And they know that. So they market under the brand name and they make a lot more money. And watch, the government says the active ingredients have to be identical. And if they're not, you get in trouble. That's why a generic works the same as a brand name. But you talk to older people about that? Oh, no. No, no. I took Lipitor and then they gave me this with Torvastatin. Nah, it's terrible, terrible. Yeah, that's all it is. The inert ingredients. That's it. It has to be. Absolutely. It has to be. It has to be. That's how it works. So, just real quick. Guy at the company yesterday, right, he's talking, and he's like, come, let me show you something. We got this formula for our insurance company, and if you get Viagra, right, it costs $3,000 a month. But if you get the Sildenafil, there you go, it's $9 a month. And he said, is there a difference? I said, yes, there's two differences. One, the price, and two, the name. But they're identical. And people don't know that. So one of the ways that I save people money at the company, save the company money, I say, you ask for a generic, ask for a generic, ask for a generic. Plus, they work through this drug warehouse, right, that I help them hook up with. So you get a 3-month supply of that drug for $20. Right? And the largest single issue dealing with employees is the cost of health care. That's why some employers are dropping health care, because it's just too much money. They can't afford it. So hopefully things will change. But that's why. So you always ask for the generic version. Right? Yeah, for the newer drugs that come out, then no. That's why you only see them under the brand name. Right? You can only get it under the brand name. That's why people, oh, I got to get the, Motrin. Yeah, I gotta get Motrin. Gotta get that Motrin. And it's like $99 for $150. And then you get the Wellbutrophin, right? And it's $8. And people don't get it. They don't know. Well, now you've been schooled. Now you know. So always ask for the generic when possible. But here's the other thing too. That's why pharmaceutical reps, that's why they come in and they bring you lasagna and cheeseburgers for lunch. And then they give you, here, doc, here's all the samples you need. Because watch, what does the doc do? Then I'm going to start you on some cholesterol-lowering drug. Let me see what I have in our sample. And he says Lipitor. And guess what he writes for the prescription? Lipitor. That's how it works. So it's a racket. It really is. And here's the other thing. Watch. Do you care how much a drug costs if you're not paying for it? No. Right? Do you care that Viagra, well, you probably don't, but is $3,000 a month? If you're not paying for it, your insurance company's paying for it, right? You don't care. But that's what you got to do. Just don't get sick. Read the textbook. Write that down. Tell me, you got that? No, I'm not done yet. Tell me you found that. So I'm going to explain to you ACE inhibitors and ARBs in 2 seconds. Because there's a really nice video I put together. I sound like Joey Bag of Donuts. Yeah, I did this great video. Guess what ACE inhibitors inhibit? How long does angiotensin 1 last? So if you take an ACE inhibitor, you prevent the conversion of angiotensin 1 to angiotensin 2. The result is that you will get arterial vasodilation. And, if the arteries dilate, what do you reduce? Preload or afterload? If the arteries dilate, do you reduce preload or afterload? Afterload. Afterload. So how you remember this? I just thought of this. A for artery. Afterload. It just came to me in my dream. So the arteries are dilated. And, watch, you inhibit the effects of aldosterone. And what does aldosterone do to blood volume? So aldosterone, by inhibiting it with an ACE inhibitor, you reduce what? Preload or afterload? No, you did. Yeah, we already covered the aldosterone part. Preload, because you're reducing venous return. That's why everyone who has CHF is on an ACE inhibitor, because it doesn't jack with the force of contraction of the heart like a calcium channel blocker would, but it's an arterial vasodilator, and it reduces blood volume by inhibiting aldosterone. Say yes.
So A1, like, it's a mild dilator.
What is?
Or
It's a constrictor, but it only lasts 30 minutes. So when the arteries were constricted for A1 for 30 minutes, they're ultimately going to dilate when there's no more A1 around.
because it can't turn into A2.
There you go. Tell me you got this. Right. ACE inhibitors prevent the conversion of angiotensin 1 to angiotensin 2. Angiotensin 2 is a massive arterial vasoconstrictor. So if you ain't got that, the arteries are going to dilate. That reduces afterload, right? Resistance to blood flow. And it also reduces or prevents the release of aldosterone from the adrenal cortex. And aldosterone raises your blood volume by reabsorbing sodium back into the blood. So if you decrease your blood volume through the inhibition of aldosterone, then that decreases preload. And that will reduce the stretch of the heart. And you don't want to overstretch your heart when you got CHF. And if your left ventricle's jacked up, right, don't contract so hard, you don't want to be pushing blood through arteries that are this big, right, because you're like, oh, got to develop more pressure. So you want to make the arteries bigger so the heart doesn't have to generate as much pressure. Say yeah. Does that make sense? All right. Now, one of the side effects, and I'm not going to get into all the chemistry, and what's really interesting is that statement implies that I know it, and I don't. I know a little. I don't want to talk about it because it wouldn't be good information. In the last 10 minutes, I've been doing pretty good. There are some people who take an ACE inhibitor, they get a cough, right? That's one of the side effects associated with ACE inhibitors. So really smart people with tape and pocket protectors, watch. What are arteries made out of? Yeah. It's amazing how many people don't know that. In the vein?
Yeah.
No. Yeah, that's just very, very... Watch, in order for angiotensin 2 to exert its effect in the arteries, you're not going to believe this, it has to bind to angiotensin 2 receptors. Say yeah. And on the adrenal cortex, that's the outer part of the adrenal gland, by the way, you have angiotensin 2 receptors on the cells of the adrenal cortex. Yeah? So, real smart people with the tape and the pocket protectors, they came up with a drug called an angiotensin 2 receptor blocker, an ARB. So it blocks angiotensin 2. You still make angiotensin 2, but in order to exert its effect, it has to bind with an angiotensin 2 receptor. So if you block that angiotensin 2 receptor in the cells of the adrenal cortex, no aldosterone. And if you block the angiotensin 2 receptor in the smooth muscle of the arteries, then it can't cause it to constrict. So those are the newer drugs, like losartan. That's an ARB, right? So they have, what is that called? Losartan Redic. What's the combination now? They got a new one. Yeah, HT. So that's losartan and hydrochlorothiazide. Yeah. So they like doing that. Also, the ARB is that little thing on those ghost shows where it goes into people and they start acting real goofy. You know, the ARB. What is that? Oh. Yeah. That is the renin-angiotensin-aldosterone mechanism, and then the function of ACE inhibitors and ARBs. Say yeah. What? Okay, hang on. Here we go. Where am I? Did I explain to you the effect of atrial natriuretic peptide? Did I explain that? The stretch of the right atrium? I'm gonna touch on it, and then I'm gonna explain. Did I explain to you BNP in that video? Well, that's just a big rip-off. Watch. Watch. Here we go. Where does all venous blood enter? What part of the heart first? Good. There are specialized cells in the right atrium that respond to stretch. How do you stretch your right atrium? By adding more venous blood back to it. So in response to increased blood volume in the right atria, you're going to stretch your right atrium. When you stretch it, specialized cells are going to release into the blood atrial natriuretic peptide, ANP. Now watch. ANP is the only hormone that lowers your blood pressure. What does natriuretic mean? Right, it means sodium, getting rid of sodium. You're not going to believe this. In the distal convoluted tubules, there's a pump. What? Never heard of that. I'm going to have to write that one down. There's a pump called the sodium-potassium pump. You know what's really disturbing? I told you, last summer or summer before. I explained to him, she was going into the fourth semester, I explained the sodium-potassium pump, and she looked at me, she goes, we have a pump in our body? No. ANP inhibits the sodium-potassium pump. So if you inhibit the sodium-potassium pump, the sodium get pumped into the blood and potassium get pumped into the urine. And if sodium stays in the urine, what stays with it? So what happens to your urine output? What happens to your blood volume? Goes down. Venous return, less stretch, no longer a signal for ANP. Boom. So ANP inhibits aldosterone, and aldosterone inhibits ANP because they're insulin and glucagon, right? Yeah, ANH is the same thing. I actually learned it as ANS, atrial natriuretic factor. They're changing these names. That was before they had TV and radio. ANP, right? Because they're diametrically opposed. One lowers your blood pressure, one raises it through the same mechanism. Can you take ANP to... Yeah, they're actually working on ANP, but ANP has some other effects in the body, actually on the brain. That's why they're... it's not like a drug that they can use regularly. Okay, now watch. And then you're going to indulge me. I burned it just a little bit. Plus I'm sick. Nobody cares. Yeah. Hang on. I forgot what I was going to do. Oh, okay. I guarantee you this will come back and bite you right square in the duodenum. Not even lying. I guarantee you, I wish I was there. I wish I was a freaking fly on the wall. When you guys get in the clinical and they talk about this, they're going to talk about this. Watch. And I don't care. I don't care. I don't. Normal heart, right? You add more blood back to it, you stretch it, you line up the actin myosin so the force of contraction is greater, right? Normal heart, no big deal. In someone who's got a damaged left ventricle, to make up for the damaged part, the good parts have to stretch. So this is as good as it gets. You got me? So if you add more blood back to the heart, and you got a jacked up left ventricle, what are you going to do to it? You're going to overstretch it. Now, listen up, because this is true. When you overstretch the left ventricle, there are specialized cells that release into the blood a hormone called BNP, brain natriuretic peptide. The reason it's called brain natriuretic peptide is it was first isolated in sheep's brains, but it is released by overstretched left ventricular cells. Are you overstretching your left ventricle right now? Yeah, that wouldn't be good. So BNP works the same as ANP. You got me? But you only see it in the blood when your ventricle is overstretched. And if it's overstretched, what do you have? You have CHF. So one of the ways that a doctor can determine if your shortness of breath is related to an exacerbation of your CHF, or maybe you got a cold like Timmy does. Nobody cares. That was for effect. Is to draw BNP level. And if it's elevated, then their shortness of breath is related to their worsening congestive heart failure. So this is a blood test now that they can monitor people with CHF. D, have you ever drawn a BNP? Yeah. Yeah. I don't know what the norms are. It's like something like less than 300 or something like that. Yeah, I was like, yeah, that's ridiculous. I don't know the exact numbers. You can learn that in clinical. My point is that the higher that number, the more the ventricle is overstretched. Therefore, the worse the congestive heart failure is. Say yes. So that's that. All right. It's usually not used to diagnose congestive heart failure. It can be in conjunction with other things, echocardiogram, other labs, clinical presentation. But it's really good at looking at how the congestive heart failure is being medically managed, right? So do we got a diuresis guy because he's got too much volume on him? Do we got to reduce the afterload, dilate him out a little more because his heart's failing? Things like that. Yeah? Tell me that makes sense. All right. Just real quick, with an ACE inhibitor, what electrolyte do you have to worry about? That's right, because you're not getting rid of potassium. And the only way to get rid of potassium, for the most part, is to pump it out. There you have it. And then you missed the clip of Davey getting shot. Yeah, he did. Too bad for Davey. Yeah, they gave him some water. Do you want to see that part or no? Yeah, I don't think so. Watch it on your own time. Okay, now I forgot what I was going to do. It was really good, too. Huh? What were we talking about? Oh, so watch. The drugs used to treat congestive heart failure are ACE inhibitors to dilate and then inhibit aldosterone, right? So they reduce afterload and preload. You're going to have to give them a diuretic, too, because you want to make sure that you keep that water off them. And then you want to give them a positive inotropic agent. So you give them digoxin to increase the amount of calcium to increase the force of contraction. Say yeah. Make sense? So when you're giving them an ACE inhibitor, you got to monitor that potassium, and you're giving them Lasix, and now you got to chase potassium. So potassium, and CHF. That's what you have to remember. Yeah? Okay. All right. Good. We did real good. What's next? Huh? Okay, good. Right. I tried explaining the long way a couple of years ago, and I started having students drool. They're like, I'm not going to explain it that way. I'm going to simplify it. Say, yeah. I told you. I'll never forget it. It was a Monday. That potassium and hydrogen ions have a difficult time being filtered by the glomerulus, so they have to be secreted. Bicarbonate, on the other hand, can be readily filtered by the glomerulus. Yes? So if there is a buildup of hydrogen ions in the blood, bicarbonate gets reabsorbed and the hydrogen ions get secreted. Yeah, I'll show you that in a minute. Now, when your pH begins to drop, in the proximal convoluted tubules, write this down, there is a sodium-potassium exchanger. You got me? And it will take sodium that was going to get peed into the toilet and exchange it for potassium that was going to remain in the blood. So the potassium goes from the blood into the collecting tubules and peed out, and the sodium gets from the collecting tubules into the blood. Are you with me? Now, again, what's more important, to maintain your pH or to maintain your potassium level? So as the hydrogen ions begin to increase, the sodium is no longer exchanged for potassium. The sodium gets exchanged for hydrogen ions. So the hydrogen ions get exchanged and dumped into the urine, exchanged for sodium. So if you're not exchanging the potassium remains in the blood, and what happens to the blood levels of potassium in an acidosis? They go up. That's why acidosis causes hyperkalemia. What does acidosis do to neural activity? It decreases it. Guess what high potassium does to neural activity? Decreases it. So always think acidosis and hyperkalemia. See, makes sense? What do you? Okay, let's simplify this. Okay, watch. Just remember with calcium and albumin bus, more important to maintain the pH than the calcium, right? So in the kidney, there is a potassium-sodium exchanger, right? So normally, sodium gets reabsorbed back into the blood and potassium gets dumped into what's soon to be urine, right? So you're eliminating potassium. Now, if your pH is dropping because the amount of free-floating hydrogen ions in the blood goes up, then that sodium-potassium exchanger becomes a sodium-hydrogen ion exchanger. So you get rid of the hydrogen ions and then exchange it for sodium, but the potassium remains in the blood. So acidosis leads to hyperkalemia. Make sense? Kalemia, kalemia. Huh? That means too much potassium.
So the exchanger becomes sodium and hydrogen?
Yes, and the potassium remains in the blood.
And so what is the sodium and the calcium exchanger for?
That's found in heart cells. The sodium-calcium exchanger is activated when digoxin inhibits the sodium-potassium pump. You got to get rid of the sodium, so the sodium is exchanged for calcium in the blood. That's why you get increased amounts of calcium. That increases the force of contraction. That's how digoxin works. What? Yeah, you want something more? I'll always give you a couple of softballers. Yeah, I like simple. I'm writing that down. Savoy 6, Savoy 6, this is Bulldog. I can't stand myself sometimes. Well, most of the time. I don't know how you guys even show up. I wouldn't. You know what I do? I'd stand outside that door and wait till I left and it'd trip me. Yeah. Dang it. You know what I'll have you do? I'll sit here and everyone walk by and just punch me real hard in the shoulder. Okay? All right. What else? Come on. We're going to knock this out. Got to feel good about herself. I went over the B1 and creatinine. Yes? I don't have to go over that. Okay. So watch. And again, couple of softballers here. Blood urea nitrogen and creatinine are the two blood tests that look at kidney function. The other one they look at is what's called glomerular filtration rate, right? Literally, GFR, how much plasma is being filtered by the glomerulus each minute. I'm not going to get into how you calculate it, but labs can calculate it, right? And glomerular filtration rates of greater than 60 mLs per minute per kilogram. So it's based on body weight. That's normal renal function, normal glomerular filtration rate. So if it starts dropping below that, then your kidneys are beginning to fail. It's that simple. All right? Now, watch. The afferent arteriole takes that blood under pressure into the glomerulus, right? So this weekend, oddly enough, I made spaghetti. And I noticed that when I strained my spaghetti, the spaghetti stayed in the spaghetti strainer. Yeah. So red blood cells, white blood cells, and albumin are big. They should never be found in the urine. So they leave the glomerulus and remain in the blood. Now watch. Glucose is small. It will get filtered and end up in the collecting tubules. But watch. The renal threshold for glucose reabsorption is 180 milligrams per deciliter. If you're not a diabetic, your blood sugar never gets above 180. So should you ever have glucose in your urine? No, because it will all get reabsorbed back into the blood. But if you are a diabetic, say your blood sugar is 300, your kidneys aren't going to be able to reabsorb all that back into the blood, and it will end up in the urine. So that's a quick and dirty way to determine if somebody's diabetic. Piatinus cuppets, they dip it for glucose. If it's positive for glucose, they're diabetic. And the higher the amount of glucose in the urine, that correlates with how high that person's blood sugar is. So the more glucose in the urine, obviously they go +1, +2, +3, +4. That correlates with how high their blood sugar is. Say yes. Now, other things they look at, leukocyte esterase, which is an enzyme that's released by white blood cells in response to infection, right? Nitrates are also released by white blood cells. So if you have nitrates in your urine, you have a urinary tract infection. Say yeah. That's what shouldn't be in urine, right? You shouldn't have quarters, nickels, or dimes in your urine either, or green pencils, or an iPhone. If you want to include those, that's fine by me. Okay, what's next? Huh? That's the last one? It isn't what? You can't interpret these blood gases? What's wrong with you? We were just interpreting them right before you came here. These people were getting it. They're like, Tim, come on, cut it out. All right. Yeah, watch. Okay, watch. First of all, I'm going to tell you this, right? You follow? Write this down. This is how they're going to teach you in nursing school, so why do I have to be any different? That freaking nickel keeps falling off that table. Rome is how they teach you in nursing school. D. Mallory, you can back me up, yes? Maybe not. Okay. Respiratory opposite, metabolic, equal. Do you ever hear this?
We just learned that in Puerto Rico and Monday, elevator, like, one go up together.
Yeah, no. Right. Yeah. I mean, I'm just going to tell you this. Watch. Respiratory opposite. That means when the PCO2 is elevated, that drops your pH. If the PCO2 is low, that increases your pH. That's respiratory opposite. You got me? Metabolic equal means when your bicarbonate is up, your pH is up. When your bicarbonate is down, your pH is down. That's respiratory opposite, metabolic equal. Yeah? Can I explain it now, how you actually interpret these? I'll just give you a couple and then just learn. Right. And when you get into clinical, if you have to actually remember this stuff, yeah, pretend like you don't. So when the instructor's going to, you follow? Watch. I actually care if somebody doesn't let. I lost sleep over that. Instead of getting 10 hours sleep, I only got 9 3/4. Watch. I'm going to explain it to you. I'm going to walk you through one. You with me? Then I'll give you one. When you get an arterial blood gas, the first thing that's going to show up, you're not going to believe this, is the pH. Now, this is new. So the pH is a measure of free-floating. I know, right? PO2. PO2 is the amount of oxygen dissolved in the plasma. Isn't that right? You got me? And that's measured in millimeters of mercury because it's the pressure. Now, and then you look at O2 saturation, and that's the amount of oxygen bound to the iron on hemoglobin. And normal is 96 to 98%. Then you look at PCO2. And how you remember PCO2 is you just take the 0.35 and 0.45 of the pH and drop it down, and that gives you the normal range for carbon dioxide. Can I tell you something? I actually watched Joey Bag of Donuts video, and I saw that, and I stole that because I thought, okay, I'll give him that one. Right? Look, I give credit where credit is due. I thought, okay, yeah. Right? You learn from me. And then bicarbonate, because you learned bicarbonate's electrolyte, 22 to 26 milliequivalents. Got that right now. Working that with the biggie. Are you with me? Now watch. This is where people get goofy, and I'm going to not make it's going to make it good. PO2 and O2 sat have nothing to do with pH. The only reason you look at PO2 and O2 sat is to determine if that person needs supplemental oxygen. That's it. The two things that are going to determine the pH of the blood are PCO2 and bicarbonate. Now, that's why I had you learn that equation day number 1, right? It will come back and rear its ugly head. Now, every time I write out this freaking equation, I always end up writing over here. Right? I'm going to do it good where it fits on the page. So here we go. And you know what I did? And I'm going to change that, right? I adjust based on the needs of the student. That sounded actually sincere. What? I made it fit, by the way. What system controls carbon dioxide? All you need to remember, just remember this, CO2 is an acid. So CO2 and free-floating hydrogen ion, same thing. You got me? Now, watch. If the amount of carbon dioxide measured as a PCO2 goes up in the blood, what's going to happen to the pH? It's going to drop. Now, what system controls bicarbonate? The kidneys. So what's the only system that can compensate for a respiratory pH disturbance? The kidneys. Say yes. Do you understand that? So when you talk about compensating, you talk about one system's failing, the other system has to help out to try to normalize that pH. Who's following me? All right? So if the carbon dioxide, which is an acid, goes up because your lungs ain't working so good, then what does the kidney have to do? How does it compensate? By reabsorbing more bicarbonate. So the amount of bicarbonate in the blood should go what? Up or down if the kidneys are helping out? They should go up. Say yes. Now, watch. Given this scenario right here, right? Just watch. I'm making this up. The pH is 7.30. Is that an acid pH or a basic pH? It's an acid pH, right? And what I'm telling you is that the PCO2, in this example I'm giving you, is 60. So is that higher or lower than normal? And if it's higher than normal, the lungs are holding on to carbon dioxide. The lungs aren't working good. So what's causing this acidosis? The respiratory. So this is a respiratory acidosis. And it's going to force the equation this way. Right? You're going to make more free-floating hydrogen. So, what's the only system that can compensate for a respiratory acidosis? The kidneys. So, how would the kidneys compensate? Not releasing, reabsorbing more bicarbonate back into the blood. So, what should happen to the circulating level of bicarbonate if the kidneys are helping out? That should go up. So if the pH was 7.3 and the PCO2 is 60 and the bicarbonate was 28, is that higher or lower than normal? It's higher, right? So is the kidneys compensating? Yes. But is the pH still acidic? Yes. So this is a respiratory acidosis that's partially compensated by the kidneys. It's partially compensated because the kidneys are moving in the right direction, but the pH is still acidic. Say yes.
So all that measures, all that stuff before it starts working?
What?
So blood gases.
Yeah. You don't know that. It could be before, during, right? It depends on when you draw the blood gases, right? Now, in a respiratory situation like that, where someone all of a sudden they can't breathe, right? Somebody sticks a dirty sock down their throat. They're going to retain CO2. It takes hours, sometimes days, for the kidneys to kick in. So the kidneys may not compensate. So if the bicarbonate was normal, it was 24, then the kidneys have not kicked in at all. So this would be referred to as an uncompensated respiratory acidosis. The kidneys haven't done anything. If it stayed between 22 and 26, you want it to be higher because that would help normalize that pH.
So if your bicarbonate level is up more than 22, 26, you know, your kidneys are trying to compensate?
Right. Now, here's the other thing. The most common acid-base disturbance is an acidosis, either respiratory or metabolic. So you always look for the acidosis, all right? Let me give you one, and I'll walk you through it, all right? So here we go. No, don't even think like that. I'm stopping you there because I don't want you to think bad. Oops. Oh, yeah. That's a 72, 71. All right? So, again, you're not going to, I'm not going to give you any clinical information. You just interpret it kind of in a vacuum. And again, you're never going to do that, right? And you don't draw blood gases on people who are coming in for a physical. People who are getting arterial blood gases drawn on them, they are sick. ICU, ER. Those are the people who are getting blood gases. Or people who are on the floor who are going to be transferred to the ICU. Okay. So you look at the pH. Is it acidic, basic, or normal? It's acidic. Right? So this is an acidosis. Now you look at the PO2 and the O2 sat. High, low, or normal? They're low, so you better give this person some oxygen. Give them some O's. Give them O's. Yeah? Now, you look at the PCO2. Is the PCO2 high, low, or normal? It's high. So the PCO2 is elevated. And CO2 is an acid. So you are retaining acid, right? So what's causing this acidosis? This is a respiratory acidosis. Now, look at your bicarbonate. So it is normal. Now, have the kidneys caught on at all? Are the kidneys helping at all? No. So because the kidneys have not caught on at all, where the hell did they catch on? This would be referred to as an uncompensated respiratory acidosis. Do you see this? Now, what you got to do is, this is when you look at your patient, and if they're breathing like this, and you listen to their lungs and it sounds like it's full of fluid, then you better be on the phone with respiratory therapy and the doctor, because you're going to have to put a breathing tube and put them on mechanical ventilation, or they're going to be taking a 6-foot dirt nap. You got me? And this is why the ability to interpret these things rapidly can be the difference between someone living or dying, and that's a fact. Now, and you don't know when, I've had to make decisions about this when you work in an ICU and the patient starts going bad. You got to get respiratory therapy up there, or you have to do it. You have to intubate them and put them on a ventilator until you can get the physician on the line. Otherwise, they'll be dead. So you got to know this stuff. All right. How many people followed that? Right, and sometimes it does. Sometimes it does. They don't kick in. Sometimes they don't kick in for a while. Then what you do is you correct the problem that caused them to retain CO2. Like you stop giving them drugs that knock them out and suppress their breathing.
But I want to take the ABG just like a snapshot.
I'm covering that bicarbonate up, but it's not covered up there. Tell me you understand this. Yes, that's why I always say that if you live long enough.
So really you're looking at the pH.
Right, now hold up. All I wanted to do in this little problem here is show you that if the PCO2 is elevated and the pH is low, this is a respiratory acidosis. You got me? And what's the only system that can compensate for a respiratory acidosis? The kidneys. Just stop right there. Don't think anything about nothing. All right? So, watch. That's why I had you do that little equation. 250 big ones, no little ones. Remember that? Remember the equation that you love to hate? Which way does the equation go, George? Watch. The cells, through metabolism, are making more hydrogen ions than normal and dumping them into the blood. What's circulating in the blood that could grab them and prevent them from being free-floating? And if they grab them and lock them up in carbonic acid, what's going to happen to the circulating level of free bicarbonate? It's going to go down. Tell me you got that. So watch. Watch. Let's go to the equation you love to hate. If you take this, and if you look at this, right, only one thing affects CO2, right? Our respiratory, because it's controlled by CO2. You got me? But on this side of the equation, metabolic, there are two things that can affect it: bicarbonate and free-floating hydrogen ions. So, yeah, I don't even know why I said that. Right, forget that. As I'm thinking about what I was going to tell you, it's going to confuse you. Forget that. So watch. If the amount of free-floating hydrogen ions in the blood goes up because the cells are making acid, right, lactic acid, you with me? What's going to happen to the amount of circulating bicarbonate? It's going to go down because the equation is going to be forced that way. Are you with me? You know this. You remember it from day number 1, right? So if you're making acid at the cell, what's the only system that can help out with a metabolic acidosis? The respiratory system, right? So if you're making more acid at the cell, you have to get rid of more acid at the lungs. So you have to breathe faster and deeper when you're making more acid at the cell to try to maintain that pH. How many people followed this? So let me give you an example. All right? Watch. Hold up. Let me just do this. I swear. And I'm not trying to cut you off, but I know where this is going. And I've done it. I've seen it before where people, just compensating partying. Let me just handle this, right? And then we'll build on it. Are you ready? Now watch. All right. So again, how you interpret this is you look at the pH. Is it acidic, basic, or normal? So it's acidic. Right? So this is an acidosis. Now you look at your PO2 and your O2 sat, right? Give them some moles. Yeah? Now you look at your PCO2. Is the PCO2 high, low, or normal? It's normal, right? So you know that the lungs aren't causing this, and you know the lungs aren't helping out because the PCO2 is normal. You got me? Now you look at your bicarbonate. Is your bicarbonate high, low, or normal? It's low. So what's happening is that the cells, through metabolism, are making more hydrogen ions and dumping them into the blood. What do you have in your blood that can grab them and lock them up? So if you're making more hydrogen ions than normal and bicarbonate's grabbing them up, what's going to happen to the circulating level of free bicarbonate? It goes down. So in this little example, whoops, where is it? This is a metabolic acidosis. Are you with me? And what's the only system that can compensate for a metabolic acidosis? And is the respiratory system compensating? No, because the PCO2 is normal. So this could be someone who has, I don't know, they got a bad ticker, and then some nurse gives them too much morphine for pain, and they can't increase their respiratory rate because they're all doped up, or they didn't read the textbook. So, did you follow this? How many people follow? This is... Wait, how many people followed this? That's very good. I don't even want to talk about that. I've never heard of that. Never heard of that. Never heard of, I don't want to talk about it. All I want you to know is right now the difference between a metabolic and respiratory acidosis. And if you can tell me and make me believe that you know the system that will compensate if one system is failing, yeah? You're okay. How many people followed this? Don't... Hold up. We got the cart before the horse, right? How many people see this? You get this. That's good. Now do me a favor. Take like 5 minutes, please. Get something to drink, and then when we come back, I'll explain that to you. All right? And if you, look, you know how you have teachers, right? They go over something, and they think to themselves, how can you not get that? But how can you not get that? Do you understand? Like, I know, I've had teachers like that, right? I don't want to be like that. Because this is high-level thinking. It's high-level thinking. It takes a lot of what you have learned, and it now begins to apply it. So I don't take this stuff lightly. I get it. But here's the thing. If you get this, I'm not even kidding. If you understand this, you will be light years ahead of everybody else when it comes to acid-base balance. I'm telling you that. You're going to be sitting next to students when you get into clinical, and they don't know what freaking pH is. And if you have the ability to at least to understand how this stuff works, you'll be light years ahead of people. I'm telling you that. And I'm going over this because I know you're going to, like, D, did you have to interpret blood gases? Yeah. Do you have to interpret blood gases when you're in school? Yeah. So they're going to lay it on you, and they're going to yell at you and point their bony finger at you. You should know that. Yeah. Man, they don't even talk like that, too. Yeah. Yeah, see? Got my big brother, who's going to beat you up. Coughing up a lung here. Hey, where are you going? Yeah. Oh, yeah? Hey. Here. I know, right? Here. Oh, wait. Yeah, you can get yourself something since you're running. Here, I got $3. Can you get a coffee with that? Don't worry about that. They're $1. Here, there's $3. You're welcome. Thank you. Diamandu. No. The PCO2 is controlled by the respiratory system. Bicarbonate? Yeah. What? About what? Say what? Say it one more time, what you just said. then the lungs would be compensating. For this one right here, no. The PCO2 would have to be lower than normal. CO2 is an acid. You got me? Right, you talked to your man, right? And he told you that he's going to have to, Kristen, but you're going to have to learn how to interpret blood gases and stuff? Right. You know, I thought back. What is that? Yeah? Yeah. Didn't I go over that? Didn't I go over that? You didn't like my explanation? Oh. Yeah. What was it about? I just look at look. You guys work all day. And then you come here and, like, the lights are down, and I talk softly. You know, I play music. And I get it. I'm surprised you show up. Can I tell you? I listened to the one video this morning, and I'm like, it does sound like I'm yelling at you. Yeah. No, but I mean, yeah, I know. That's because I'm going deaf. Yeah. It's true. I can't hear anything. Yeah, no. I saw a picture of me when I was 40. 55. And I'm like, wow, I still look pretty good back then. My girl had it. I think she shows that picture to her friends and stuff. I'm like, that ain't real. Nah. I'm very thankful that women aren't that like concerned about how a guy looks. Like, they don't want a piece of work, you know what I mean? But they're much more yeah. Yeah, no, you're right. And here's the thing. I mean, my days of trying to impress a woman with the way I look, that went away like 30 years ago. You know. That's what I told my son. I said, I get it. I get it. I understand why you're in front of the mirror doing your hair. That's all you got to offer. That's it. I never realized that. You know, when I was younger, because I had nothing to offer to him when I was younger. I mean, I want to win out with me. You're a good man. Thank you. Well, why didn't you go get yourself something? Now I feel guilty. Look, you're Jewish and I'm Catholic. We're raised on guilt, brother. Nice.
I had confirmation class today, like before this, and one of the Catholics was serious business. Like
Yeah.
we were talking about like they explained the calendar. Have you seen like the circle calendar?
Yeah.
She explained that to me how the reason why you don't have church that Saturday after Good Friday is because that's the day he died.
Yeah.
I'm just like, I mean, I understood it, but it's like you guys were like legit, like this is legit. And we were talking about like the saints and stuff, and how it's just like.
Here's the thing. The only thing I don't like about it is that there's nothing in the Bible that says a priest can't marry. The only reason they prevent priests from getting married is that when the priest dies, everything goes to the church. That's why the church, Catholic, the church is one of the richest.
What do you call the? I don't know what it's called in English. What do you call the one that can help the priest and the he's like a helper. He can be married, but he has to ask permission. The church has to ask permission to his wife.
Oh, really?
In English it's called in Spanish it's called a diácono. I don't know what it's called in English.
I don't know.
I thought that was crazy. Like they have to ask the wife.
That's crazy. What? Yes, you can have a problem. But one of the systems is compensating. That's fully compensated. If your pH is normal, but the other two are off. And people are walking around with that very situation. And I'll give you an example of it. You will. No, because carbonic acid is going to go one of two ways. It's going to break down to hydrogen ions and bicarbonate or CO2 and water. It doesn't matter. A deacon, yeah.
They have to, when he goes to become, when they actually assign him, there's a temporary and then there's a permanent. The permanent is completely permanent, and then there's a temporary here working their way up to be a priest. Well, when you're going to become a permanent deacon, you have to ask the wife if she's okay with it. Because if she's not okay with it, like if something were to happen in the church, he has to take time out of being with his family to go to the church and like go to hospitals and blah, 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 blah.
Yeah, it's like a full-fledged ordination.
Yeah. She was teaching me the hierarchy of the church. Just like,
You know, I was an altar boy, if you can believe it. Look, the Lord giveth, and the Lord taketh away. When I was 14, my mom said, no, 16. She said, you can determine whether or not you want to continue to go to church. And of course I said no. And she'd go, Timmy, are you going to church? I had my bedroom on the bed. I don't know, Ma. You're a heathen. Yeah. I'm not even kidding. The Catholic, man, you can be, if you talk to me long enough, you can convince me I shot Kennedy. Oh, yeah, I did it. Yeah. It's awful. Oh, yeah. Oh, yeah. 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 Oh, yeah, Catholics and Jews, man, forget about it. They're, like, guilt-ridden. And then it says in, like, the religion, like, if you think about a woman, then you're going to hell. I'm like, man, cut it out. No, okay, we're not arguing religion. We're talking about blood gases now. Do you see how I nipped that one? Okay, here we go. Watch. Real quick, I'm going to go over partially and fully compensated. The two examples that I just gave you are uncompensated. Are you ready? Okay, now watch. Did you watch that video I put together? It was my finest hour. Yeah, it made sense, right? Okay, so watch. Here we go. Okay, now, let's walk through this a minute, all right? First of all, look at the pH. Is it high, low, or normal? It's acidic, right? So this is an acidosis, right? You look at the PO2 and the O2 sat. That's low. Give them some O's, right? Now you look at the PCO2. Is the PCO2 high, low, or normal? It's high. Stop. Because CO2 is elevated, right? And you got CO2 is an acid. High levels of CO2 are going to produce an acidosis. So this is a respiratory acidosis. No question. Now, what you want to do is you want to look at the kidneys, because the kidneys are the only things that can compensate for an respiratory acidosis or alkalosis, right? The kidneys compensate for a respiratory issue. How do they compensate? Right, they'll reabsorb bicarbonate that was going to end up in the toilet. It will reabsorb it back into the blood and excrete hydrogen ions, right? So if the kidneys are compensating, helping out, what should happen to the circulating level of bicarbonate? It should go up, right? Right? It goes up because you're reabsorbing it back into the blood. It was going to get peed into the toilet. Now you're bringing it back into the blood. So, let's see, where is it? So are the kidneys compensating? Yes, because the bicarbonate is higher than normal. But the pH is still acidic. So this is a partially compensated. Partially compensated. Why is it partially compensated? The kidneys are moving in the right direction, but the pH is still not normal. Say yeah. All right? So. Okay, now watch. Watch. You don't look at the pH and then update your Facebook status, right? You look at the other things, right? And then again, you what's referred to as clinically correlate. You don't interpret blood gases in a closet. You're going to have a patient you're dealing with, right? So you look at the pH. Is the pH high, low, or normal? It's normal, right? But you don't walk away. PO2, O2 sat, high, low, or normal? Low, so you want to consider giving them some oxygen. Now watch. Remember this. Always look for the acidosis. The most common acid-base disturbance is an acidosis. You got me? So you look at the PCO2 and you look at the bicarbonate, all right? Now, I'm going to cover it up. if you look at just at the PCO2, are you getting rid of more CO2 than normal, or are you retaining it? You're getting rid of it, right? So it's lower than normal. So if you should look at this, if you just looked at the PCO2, the pH should be alkaline, right? You're blowing off more CO2 than normal, right? So people aren't going to come into your emergency room going, I've been breathing like this for 17 years, right? So you look at the bicarbonate. The bicarbonate, is it high, low, or normal? It's low, right? So if you look, the cells through metabolism are making more hydrogen ions than normal. The bicarbonate that's circulating is going to grab those excess hydrogen ions, lock them up in carbonic acid, and they'll break down to CO2 and water. Are you with me? So, in this case, where the heck is it? Oh, I lost it. Ah, there it is. What you're looking at is a metabolic acidosis. Why? What did I tell you? Look for the acidosis. You got me? So in this case, because the cells are making more hydrogen ions than normal, this is a metabolic acidosis. What's the only system that can compensate for a metabolic acidosis? The respiratory system. So if you are making acid at the cell, the lungs have to get rid of acid at the lungs, and CO2 is an acid. So the lungs have to get rid of more CO2 than normal because you're making more acid through metabolism. Yes or no? Yes or no? So this, where the hell is it, is a fully compensated metabolic acidosis. Why is it fully compensated? Because the pH is normal. And the bicarbonate was low, right? So again, watch. No one's going to be able to hyperventilate that long for their kidneys to start kicking in and compensating for a respiratory alkalosis. Do you follow that? Because you could look at this and say, well, this could be a respiratory alkalosis that's being compensated by the kidneys. It's not. Look for the acidosis. Always look for the acidosis. Yep. No. Stop. 8 o'clock. Make sure that I go back at 8 o'clock and get her remarks off there. Disregarding. Watch. The kidneys can't do anything in a metabolic acidosis right away. Do you understand that? Do you understand that? So if initially you start producing more hydrogen ions, the only system that can initially compensate for that is the respiratory system. So the only system that can compensate initially for a metabolic acidosis is the respiratory system. And the only system that can compensate for a respiratory problem is the kidneys. Watch. That's why, look, if the respiratory system is going bad, right, and the PCO2 is building up, you can't say, well, let's wait a couple weeks and see if the kidneys kick in, right? You have to mechanically ventilate those people. Tell me you got that. You're overthinking this, Christine. You really are. I think you are, because there's no way. I got this. I don't know. No, the CO2 wasn't normal. CO2 was low. Yeah. Did you watch that video with the little thing with had the CO2 and the bicarbonate in the little U-shaped thing? Anna's just over there eating carrots. What are you eating? Oh, Cheetos? Anna girl. What's that? I got a video on how to interpret blood gases. It's called How to Interpret Blood Gases. Can I show you one more? Okay. How many people are getting this? Yeah? Yeah? Watch. Wait, no, it's recording. I never stopped. I'll have to cut that up. Got that religious stuff in there. Let's see. All right, I'll give you a little. I'll give you a little background information. Right, projecting here. At the end of the semester, right? Final grades are in. You go on your computer and you look at Web Advisor, and you see your final grade. This could happen. I don't know who says that. That is so wrong. I hate me too. And plus my neck hurts, Anna. You know, I've never gotten in my life a massage. Yeah, I had a student like 3 or 4 years ago. Yeah, never. She gives massages, so she gave me a gift card for an hour-long massage. And I'm like, that's kind of weird. So I gave it to my girl. She loves it. So now every weekend she comes down, I have to buy her a massage. What the hell is that? Why don't you get one of those machines? You know, it kind of rolls on you. Yeah. Yeah. What the hell is that? I quit. I'm very nice, Anna. I'm too nice. I know. I know. Mhm. You know what I'm going to do when I hand your quizzes back? I'm going to give you paper cuts. Because I want to be mean. She's Fatica. She's over there drinking Gatorade. You got what in it? Yeah, it does. That's good for you. Who's got this blood gas? What is it? That's an uncompensated respiratory alkalosis. Right? Look at the pH. Is the pH high, low, or normal? It's high. It's an alkalosis. Yes? So you look at your PO2 and O2 sat there, okay. Your PCO2 is low. So you're getting rid of acid. So that means you're going to have a relative excess of base, right? And the kidneys are compensating because the bicarbonate is normal. So this is something that is like episodic. You look at Web Advisor, I thought I was getting a D, and I got an F. So you hyperventilate. You got me? Because you're anxious. Now, again, your kidneys ain't going to have time to kick in. So what do? You give those people some Valium. Calm them down, slows their breathing down, and then you ambulate home. Tell me you got that. Or you have them breathe into a bag. And you have them breathe into a bag to rebreathe their CO2. And the reason you have them rebreathe their CO2 is because there's not a lot of CO2 in the environment. Okay, that's all I want to talk about that. Yeah? I'm done with blood gases. Can I give you one more blood gas and see if you can really get it? If you get this, I'll give you $1. Wait, gotta make sure I got $1. What do you mean? Those exact ones? Well, yeah. Because then you're going to go home and memorize them. I don't know what he's talking about. That's a respiratory acidosis all day. Okay. No, he ain't dead yet. Mm-hmm. Not yet. Write it out. I don't want you yapping it. And then people say, hey. No. No. Yes. Yep. Where's he get? What did I say? No. The second part. Let me see. That part. Yep. Yep. All right. Anybody got something? Okay, what do you got? No. Uncompensated metabolic acidosis? No. 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 Watch. 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 You know the answer. You just don't know you know the answer. You know? Son of a... Okay, watch. Watch. If somebody's heart ain't beating so good, and they ain't breathing so good, what's going to happen to their ability to deliver oxygen to the cells of their body? It's going to decrease, right? Decrease, not completely cut it off. So they still need to make ATP, don't they? So they ain't going to be able to make a lot of ATP through aerobic metabolism. So glucose to pyruvate will predominate. Ain't that great? And some of that will get converted to lactate. Lactate, say yes. And that will form a free-floating hydrogen ion, so what will happen to the bicarbonate level? It will go down. So this is a metabolic acidosis hold up. But as that person begins to go downhill, watch it. What does an acidosis do to neural activity? Suppresses it. And what part of your brain and nerve controls the contraction of the diaphragm? The phrenic nerve. So as the acidosis, the metabolic acidosis worsens, that's going to decrease neural activity. So they won't be able to breathe as much. So they'll start building up carbon dioxide. So this is a respiratory and metabolic acidosis. You've been tricked! It is funny. Watch. This is what you will see in a person right before it's over for them. Their respiratory system will become compromised, and because they can't deliver enough oxygen down to the cells start making lactic acid and dumping it into the blood. And if you can't interpret that and know that this person is about to be on the outs, the first thing you do is you get them intubated, right? Or until you do, you ventilate them, and you ventilate them aggressively to help them blow off CO2 until you can get them intubated and get them some bicarb, and then find out why their heart ain't working or whatever the case may be. Do you understand that? So you can have both a respiratory and metabolic acidosis, and that's what happens right before you take a dump, right before you die. Right, their pH is so low, right? So low that's what happens. And that's why I asked the question, like, what does acidosis do to neural activity? So you're going to have to, and they're going to expect you to start incorporating all the stuff when you get over into your little clinical phase, right? And look, would I ever ask you something like that on a test? No, it's ridiculous, right? Never, because who cares? My point is that if you understand this, then you'll understand why this stuff can happen. Say yeah. That's the whole answer. It's both a metabolic and respiratory acidosis. No, because both systems are causing it. So if both systems are causing, there's nothing to compensate. You got me? No. But you know what, people, I love doing that to people. I know how to do this, and I throw that in there, right? And don't hate, appreciate. Tell me, but I don't know. Look, neural activity decreases. In order to contract the diaphragm, you have to have signals to the phrenic nerve. So as the acidosis worsens, neural activity becomes suppressed, so breathing becomes depressed, and if you don't breathe, then you'll build up CO2. That's why it's a respiratory and metabolic acidosis. Say yeah. All right, let's ambulate home, okay? My throat hurts. I think it's because this thing's around my neck, cutting off my carotid artery. No, I got a bunch of that. My kid actually went and got me tea. Hey, did I tell you that my kid actually snowblowed my driveway and walked? I could not believe it. Then he actually volunteered to do the dishes. So you know what I did? No, you know what I did? I actually took his temperature. I thought, you have to be sick. You're probably delusional. I always think back when I was 20 years old, was I like that? I'm like, So, the sins of the father. No, don't start that. I'll get in trouble.